Dyslipidemia is an abnormal amount of plasma lipids. Hyperlipidemia, hyperlipoproteinemia are abnormally elevated levels of any lipids and/or lipoproteins in plasma. Increased amounts of lipids and lipoproteins cause increased atherosclerosis and cardiovascular system disease risk. The lipid sources are from our diet or endogenous, formed in the liver or adipose tissue. Plasma lipids are transported in the form of free fatty acids bound to protein albumin or in the form of lipoproteins. This topic is divided into 3 parts. The first part will be about the different kinds of lipoproteins, and then I will talk about the metabolism of lipids, and finally I will discuss the different treatments. Lipoproteins are spherical particles circulating in our blood. Hydrophobic parts are in the core, such as triglycerides and cholesterol esters. Relatively hydrophilic parts are on the outside, such as phospholipids, apoproteins, and free cholesterol. The lipoproteins differ in density, size, and major lipid carriers. As the content of proteins increase, the size of the lipoprotein decreases and the density increases. The bigger the size of the lipoproteins, the higher the content of fats. There are 5 types of lipoproteins: chylomicron, VLDL, IDL, LDL, and HDL. The biggest one is the chylomicron and the smallest one is the HDL. Chylomicrons are formed from our dietary lipids in the intestines. The lipoprotein lipase causes hydrolysis of triglycerides in chylomicrons. The lipoprotein lipase is found in the endothelium of blood vessels in our muscles and adipose tissues. It breaks the triglycerides into free fatty acids and glycerols. The rest of the chylomicrons, called remnant chylomicrons, are taken up by the hepatocytes. Part of the cholesterol in the liver is delivered to the intestine via bile acid production. The rest of the cholesterol with other triglycerides are transported to the blood, but in the form of VLDL. The VLDL are converted to IDL by lipolysis via LPL in the vessels of peripheral tissues. The IDL are converted to LDL by further loss of triglycerides. The LDL degradation involves the endocytosis of LDL by LDL receptors on the liver and the peripheral tissues. The IDL and LDL both bind to LDL receptors in the peripheral tissues and release their cholesterol. That's why we call them the bad cholesterol, because thrombosis and atherosclerosis can occur, which is bad. For your information, the LPL needs an apoprotein called ApoC2 to function, a component of VLDL and chylomicron, which activates the LPL. HDL does something very nice. It removes free cholesterol from cells. There is an enzyme called LCAT, lecithin cholesterol acyl transferase, which transforms cholesterol to esters through an esterification reaction. HDL circulates through the bloodstream and incorporates more cholesterol and phospholipids from the cells and other lipoproteins, which is good for our health, and that's why we call them the good cholesterol. The cholesterol esters in HDL are transferred to lipoproteins by an enzyme called CETP, cholesterol ester transfer protein, or they are delivered directly by the HDL to the hepatocytes. There are 2 types of lipoprotein disorders: primary due to genetic defect and secondary due to metabolic diseases. A healthy lifestyle can manage dyslipidemia, such as limiting total calories, exercise, and decrease alcohol consumption. Statins inhibit cholesterol synthesis by inhibiting an enzyme called HMG-CoA reductase. The level of cholesterol in hepatocytes is decreased. The liver feels that the amount of cholesterol is decreased, so it tries to compensate by an overexpression of the LDL receptors in order to incorporate all the cholesterol coming from LDL and IDL, so the levels of LDL and IDL decrease in the blood. Also, when the level of cholesterol is decreased in the hepatocytes, the level of VLDL and LDL are decreased. The side effects of statins are hepatotoxicity. That's why we need to measure ALT levels, myopathy and rhabdomyolysis. And the biomarker of rhabdomyolysis is increased level of creatine kinase. Bile acid sequestrants, resin. They bind to the bile acids in our intestine and prevent the reabsorption. Their mechanism of action depends mainly on the positive charge that reacts with the negative charge of the bile acids. That's why they can bind to any negative charge and cause side effects. The liver tries to compensate by producing more bile acids, so the hepatic cholesterol is decreased and the LDL receptors are overexpressed, decreasing the LDL and IDL in the plasma. The side effects of bile acids are bloating, constipation, dyspepsia, steatorrhea, and malabsorption of fat-soluble vitamins such as vitamin D and K. Niacin, nicotinic acid. In adipose tissue, it inhibits hormone-sensitive lipase, HSL, inhibiting the lipolysis of triglycerides. The amount of free fatty acids in the liver and the plasma are decreased. The synthesis of triglyceride is decreased in the liver and the level of VLDL and LDL are decreased. There is another minor mechanism. It enhances the lipoprotein lipase activity, increasing the clearance of triglycerides from chylomicrons and VLDL, decreasing the amount of VLDL and LDL. It decreases VLDL synthesis through the first pathway and decreases VLDL by increasing its clearance through the second pathway. Finally, it decreases the clearance of ApoA1, a major component of HDL, decreasing the clearance of HDL and increasing the HDL levels. The side effects are mainly cutaneous side effects and prostaglandins mediated, such as flushing and dry skin. Fibrates decrease triglycerides through increasing lipoprotein lipase activity. They act on nuclear receptors called PPAR, peroxisome proliferator activated receptors, leading to transcription of regulatory factors controlling lipid metabolism and decreasing triglycerides. How? By increasing free fatty acids oxidation in liver and muscles. By increasing the expression and synthesis of LPL, breaking down triglycerides and VLDL. And finally, by decreasing the expression of ApoC2, a component of VLDL that inhibits lipoprotein lipase activity, increasing the activity of LPL. The side effects of fibrates are myopathy, GIT disturbances, and increase the gallstone formation. Ezetimibe acts on the absorption. It decreases dietary and biliary cholesterol absorption, decreasing the level of cholesterol in chylomicrons and the liver. Overexpression of LDL receptors occurs, increasing the level of LDL clearance from the plasma. Why the liver does not synthesize cholesterol instead of increasing the level of LDL receptors? It does so. That's why ezetimibe is co-administered with statins to inhibit de novo synthesis of cholesterol. The side effects are myopathy and diarrhea.